Hello, everyone. My name is Bill Mckendree. I'm the Executive Director of the Pennsylvania Healthcare Benefit Solutions Program, PHBSP. We help people navigate through the complexities of programs like Medicare and Medicaid and the private health insurance marketplaces. We provide individual counseling and patient advocacy services, and we produce community education presentations like the one you're watching now. This presentation was recorded in May 2023, and the topic is Medicare Advantage plans. I hope you enjoy it. Hello, everyone, and welcome to our continuing Lunch and Learn series on understanding Medicare. Today, we're going to continue where we left off last time, looking at the private insurance products that are part of the Medicare system. And last session, we looked at Medigaps. And this session, we're going to look at Advantage plans, also referred to as Part C plans by the Medicare system. So just to get a running start, individuals that are entering the Medicare system are going to start by enrolling in eventually both Medicare Part A and Part B. Some people get the Part A first and then later pick up the Part B, usually because at the time they turn eligible for Medicare, they are working and covered by an employer's benefit or the spouse of someone who's working, and through the spouse are covered by the employer's benefit. But at some point, ultimately, individuals are going to be looking at the total entry into the Medicare system where they pick up finally both parts, Part A and Part B. And those portions of Medicare represent the government's benefit of the Medicare system, the system that has been in place since it was created. Part A and Part B is the platform or the foundation upon which individuals in Medicare build the other components provided by private insurance. And Part A and Part B are usually referred to as the traditional or original Medicare. Part A covers some part of the costs associated with inpatient services, and Part B covers some of the cost associated with outpatient services. However, neither Part A or Part B, or Part A and Part B combined, will effectively cover the entire cost or even come close to covering the entire cost of Medicare covered services. As a result, individuals that have Medicare A and B only are aware that they're going to be facing deductibles, co-payments, and co-insurance. And maybe once a long time ago, Part A and Part B might have been sufficient, but the real costs of the cost sharing by just having Medicare A and B are fairly preclusive of relying just on those component products. And as a result, what's likely, individuals are going to turn private insurance to enhance or supplement their basic Medicare A and B. Now, in the universe of Medicare private insurance coverage, there's three components. Last time we looked at the supplements that are secondary if an individual is using Medicare A and B as their primary coverage. They're usually referred to as Medicare supplements or Medigaps. Today, we're going to look at an alternative to supplementing Medicare A and B, using instead Part C Advantage plans. And these are not supplements to Medicare A and B. These are managed care HMOs, health maintenance organizations, or PPOs, preferred provider organizations. They represent a managed care alternative to relying on Medicare A and B and supplementing Medicare A and B with a Medigap. I think the biggest point of today's presentation, aside from just examining this alternative to utilizing Medigaps in tandem with Medicare A and B, is looking for possibilities when the option of going with an Advantage plan can actually be, for some individuals, more advantageous than relying on Medicare A and B and a supplement. And really doing a pro and con comparison to the two possibilities. Regardless of whether the individual entering Medicare or in Medicare already chooses to supplement Medicare A and B with a Medigap, or effectively replacing Medicare A and B with an Advantage plan, it is likely that individual will also be seeking at least additional prescription drug coverage, referred to typically in Medicare as Part D plans. So the individual going into Medicare or being in Medicare already is very likely going to have either the first example, a Medigap and a Part D plan, or the second example, a Part C Advantage plan, and with it, Part D coverage. So we're going to focus on that second one, Advantage plans, what they are, how they work, and how they differ from the Medigaps. It's an alternative to the traditional Medicare coverage of Part A and Part B being your primary care coverage. It was created with a recognition that this was a transition from relying on Medicare itself, the government's portion of healthcare coverage, as the primary engine for guaranteeing individuals eligible for Medicare access and coverage, to a privatization of the Medicare system. Now, the Medicare Part C Advantage plans, like the Medigaps, are private insurance, and they're part of the Medicare system. But this is a exclusive reliance on private insurance companies to be the provider of care coverage for individuals that make this choice. The plans are approved and highly regulated by the Medicare system, by the Centers for Medicare and Medicaid Service. And they, to some degree, mimic the basic coverage premise of Medicare A and B, but they can do more, but often do less than what the Medicare Part A and B strategy supplemented with a Medigap. When Medicare envisioned supporting the private insurance HMOs and PPOs, they saw this as an effective way to transition out of the primary role of providing coverage for eligible individuals, to shifting that responsibility to private insurance companies, not just as a supplement, but as an exclusive obligation. And to motivate private insurance companies to accept that exclusive responsibility. Medicare is a government entity, the Centers for Medicare and Medicaid Services subsidize the private insurance companies that offer HMO and PPO Advantage plans. These insurance companies are well subsidized. The motivation to offer these products in a marketplace is significant. In a normal year, private insurance companies that are offering HMOs and PPOs as Part C Advantage plans are reimbursed or subsidized by the federal government, by the Centers for Medicare and Medicaid Services, anywhere from about $1,500 to $2,000 a month throughout the year for those individuals that they motivated to enroll in an Advantage plan rather than relying on Medicare A and B. And this is the point. When an individual enrolls in an Advantage plan, an HMO or a PPO, even though they're enrolled in A and B, even though they're required to be enrolled in Medicare A and B, they essentially don't get to use Medicare A and Medicare B for any of their coverage. That responsibility, that obligation, has transitioned exclusively to the private insurance HMO or PPO. And in return for accepting that responsibility, the private insurance companies understand, and in fact, it's the point, that they're going to be receiving a significant subsidy from the federal government for doing that. From the federal government's position, it's a way that they get out of the business of directly covering individuals that are enrolled in Medicare. It shifts the responsibility to private insurance. For the private insurance companies, it's a significant stream of revenue. Make no mistake, they would not be doing this unless they were making a significant profit from this process. But there's something else that motivates the private insurance companies to offer products and aggressively market to get individuals to enroll in their products beyond just the subsidy. And if I give private insurance company $2,000 a month, every month, but there is an understanding that they have exclusive responsibility to cover cost associated with that individual who is enrolled in that plan. They know that the maximum amount of profit they're going to make is represented by that subsidy. And the more they keep, the bigger the profit is determined by the amount of services that that customer utilizes and what that HMO or PPO plan has to pay to cover the cost of those services. So the less services used, especially the less expensive services used, the more of that $2,000 a month the insurance company gets to keep. And thus, there is a built-in incentive to minimize utilization on the part of those who have enrolled. This is not the same paradigm or the same model necessarily that the government faces. The government is not intended to make as much profit as they can from the process. Ideally, they want to break even. They want to spend what they've been allotted in that annual budget. But that's quite the opposite of the private insurance companies. The motivation in which the services are provided and how the services are managed and regulated differs from the premise of whether this is a service provided by the government or service provided by a private company. And yes, individuals that opt to use Medicare Part A and Part B government as their primary and get a private insurance Medigap as a supplement are still utilizing private insurance, but there's a big difference. The private insurance Medigap cannot deny coverage for any services. If Medicare, the government, agrees that this care, this service, this stay in hospital, this diagnostic procedure, this operation is reasonable and necessary under the circumstances for this patient, if it's something that normally is covered by Medicare, the private insurance supplement can't say, no, we'd rather not. That's the point of them being a supplement. They're obligated to pay their share of the cost coverage for that service. HMOs and PPO Advantage plans have the capacity, have the power to tell individuals covered by their products that they're being denied access to those services. And to make this even more efficient, providers in that HMO or PPO network are managed by the insurance company. And this sets an important distinction, which is often overlooked, which is often not even understood. That the nature of each model that drives how individuals are covered and how individuals access services are very different. Medicare Advantage plans are grounded in the idea of managed care, a network of providers controlled by the insurance entity and driven by a restriction, a limitation of services to effectively minimize the imposition of cost to the insurance company. And this restriction can, for some individuals seeking the maximum level of care, especially in complex and expensive procedures, a frustration that they're being, from their perspective, barred from accessing those services they think they need, when in fact even their physicians are telling them they should have. But because of the insurance's unwillingness to cover that in that case, or coming up with an alternative, which from the insurance's perspective is as good as, but from the patient's and perhaps even their physician's perspective is nearly as good at. And thus creates potential for an adversarial relationship between the insurer and the patient, even the care provider and the patient. Now, something else that Part C Advantage plans do, they do this certainly as an incentivizing to the customer to select them versus Medicare Part A and Part B and a supplement. And this has been recognized as a significant value, a significant advantage to the Advantage plans. They can do something that Medicare A and Medicare B and supplements cannot do. They can offer things that are outside the umbrella of the Medicare system. There are certain things that Medicare Part A and Part B do not cover. And if they do not cover it because it's not recognized as a Medicare covered service, then a Medigap is not required to cover that either. And thus, certain kinds of services that the individual seeks may require additional non-Medicare type coverage, like coverage for dental services, for vision services, and for things that are not truly medical, but medical-like, like healthcare memberships and wellness programs. But these are all things that are very commonly included under a Medicare Part C Advantage Plan umbrella. These are the perks. These are the things that are the incentivization for individuals to embrace the HMO or PPO. And that isn't necessarily bad if what is most important to that individual in entering the Medicare system are things that we'll call extraneous or ancillary to the fundamental inpatient or outpatient coverage. And there's lots of individuals entering Medicare that are legitimately more interested in accessing basic dental or vision coverage or access to health clubs and wellness programs, and see the advantage and value of the other things that these ancillary products and programs under a Medicare Advantage plan enriches their particular healthcare experience, is more valuable to them than the more traditional, typical medical services. So the Part C Advantage plan tends to be an all-encompassing package of things. It's not there's Part A and there's Part B and there's a Medigap and there's prescription drug coverage, and if you want dental, you're going to get a separate dental coverage, and if you want vision coverage, you're going to go out in the marketplace one more time and get a separate vision plan, and. The value is to take all of these components and roll them together into a single package. A typical HMO or PPO under the Medicare umbrella will include not only a commitment to covering at least as much of the cost that Medicare Part A or Part B would do, but also covering the cost of accessing hearing aids, which is not covered under Medicare Part A and Part B, which is therefore not covered at any part by a supplement. They even go beyond that. There are HMO and PPO programs that offer some levels of home care services. Providers that go into the individual's home to help with basic personal care necessities, or help individuals to get to their doctor's appointments, get to their healthcare service providers. And tying this whole thing together with a, for lack of a better word, concierge or utilization manager that is accessible to this individual to help them navigate through and remind them of all the kinds of things that this product provides and how to use it effectively. And in addition to those other things, it also eliminates the need to pick up separately prescription drug coverage. Not all Advantage plans build all of these elements in, but all Advantage plans represent at least some of these things. And not all Advantage plans offer prescription drug coverage as part of their package, but most do. And so by enrolling in the Advantage plan, individuals basically do a one-stop shop. By picking up their PPO or HMO, they have the expectation that their inpatient and outpatient services will receive some degree of coverage, that they will have their prescription drug coverage as well, and a inventory of all sorts of other kinds of coverage that may or may not be of value to the individual. And this ability to get it done under one package and not have to worry about shopping for the other things is certainly a value. In addition, some individuals going into the Medicare system may find the kinds of services that might be ancillary to someone else, might be just swag to someone else, to be the critical, most important thing at that moment. Obviously, these are subjective values. Some individuals are going to see none of these as essential or important. Some of these things are recognized, but extraneous at best. And for some individuals, the most important thing is covering the cost of potentially expensive, chronic, pernicious conditions that are truly in the definition of medical, either as an in or an outpatient, and understanding the potential of the cost of those services if they do not have good coverage could be economically devastating. So for some individuals, it's the swag. And it's not swag to them. It's an important aspect of their well-being. For other individuals, these things are swag. They're not that important. What is important is knowing that if they have to go in for chemotherapy, the expectation is the entire cost of the chemotherapy procedure will be paid for. The cost of their hip replacement will be fully paid for. The cost of their continuous care for cardio disease or for end-stage renal. These things are incredibly expensive, and having a product which guarantees the entire cost or most of the entire cost is fully covered by the insurance or a combination of Medicare, the government, and the supplement is the most important thing. And I recognize when I'm sitting down with a client, the possibility could be either direction until I fully understand the things that are valuable to that individual, their priorities, their needs. So the idea of what's so bad about an Advantage plan? For some individuals, nothing. Their expectations of how they're going to use healthcare services, the things that they value more than others, their priorities, may very well lead them to embracing a Part C option versus Medicare Part A and Part B and a Medigap option. It's up to the individual. As long as they understand the difference, as long as they understand the pros and cons in getting into this, and make that decision with eyes wide open. The other thing about any Part C Advantage plan, they're all going to be somewhat different from one another. And not only that, they're going to be different in themselves from year to year. The coverage promised for the current year may very well change in the next year. Nothing is for sure except from January to December in one 12-month cycle. This was the design built into Advantage plans. They can vary. They can be flexible. They can be user-friendly to achieve that particular individual's desires. And they can be flexible to vary from year to year. The insurance company standpoint to contour what the market seems to want and also what the economic necessities for the insurance company are in terms of the cost sharing. And the providers in that HMO or PPO network can also change. Every year, doctors, hospitals, care providers make new contracts with the insurance company. And those individuals that have contracted with the insurance company to be part of their network may not now include the ones you want to utilize. As a contrast to a Medigap is very knowable. A Medigap defines its coverage at the beginning of your enrollment and must stay absolutely true to that commitment throughout the life of your enrollment in the Medigap. If you choose a Medigap supplement, you absolutely know what it's going to cover. And all companies offering that level of Medigap in your jurisdiction, in your state, must offer exactly identical, the same coverage based on that category of the Medigap. You know what you're going to get, and you know that what you're going to get is going to stay the same throughout the life of your relationship with that Medigap contract. There's a certain surety, a certain confidence that I know what I've got, and it's good, it's comprehensive. On the other hand, there's absolute uncertainty as to the quality and effectiveness of the Advantage plan from year to year. On the other hand, individuals have the opportunity to not only review what the Advantage plan is offering for the upcoming year, but also change their product. So getting into a Medicare Advantage plan has multiple opportunities throughout the lifetime of that individual in the Medicare system. First off, when the individual initially enters Medicare, during that 7-month initial enrollment period, or if they're enrolling in Medicare now that they've terminated employment and they've lost their employer coverage and they're doing it based on a delayed enrollment. At the point where the initial enrollment begins, they certainly have the opportunity of selecting a Medicare Advantage product or a Medigap. During that initial period, pretty much the entire inventory of private insurance products, Advantage plans or Medigaps, are available to them. Unlike Medigaps, which essentially is a once-in-a-lifetime commitment, because with Medigaps, you are less accessible to change, less accessible to acquisition of the Medigap as time goes by. Most likely after the first 6 months of being in the Medicare system, the only way you'll get a Medigap or swap from one Medigap to another is by going through underwriting, which is potentially risky in terms of acquiring the product you want. On the other hand, Medicare Advantage plans build in the accessibility of new products as part of the value, the ability to swap products annually, in fact, possibly even more frequently than annually. Advantage plans have built into their enrollment continuation an annual enrollment period, an open period near the end of the year. It begins October 15th. It continues to December 7th of each year, where individuals can evaluate what their current products are going to do for the next year or look for new products as an alternative. And as long as they've enrolled in the new product by December 7th, that new plan coverage will commence January 1st of the next year and will disenroll them effectively from their current product. Now, they don't have to pick a new product. They can decide that the one they have is working just fine, and let it naturally roll over and cover for the upcoming year. Starting a few years ago, even that annual enrollment was extended a bit so that not only could you evaluate your product in October, November, and early December, once the year was over, you even had another crack at making a change of your existing products between January 1st and March 31st of the following year. And throughout the year, there are special situations that allow, based on the nature of that situation, the ability to flip to another Advantage plan. It is incumbent upon the nature of this product that people have a relative ease of moving into and out of the product, unlike Medigaps. When an individual is making their initial entry into the Medicare system, they're going to be faced with a big, hard decision, probably the hardest decision they're going to make throughout their Medicare enrollment, because it's going to have implications based on what they can and can't do later on. Now, most of you guys have seen this before. You've seen it in relationship to the initial entry into Medicare, in relationship to utilizing Medigaps. Here again, I'll use the chart to show comparison of how a Medicare Advantage plan is going to function as an alternative to relying on Medicare A and B. So when the individual, using option 2, elects to enroll in a Part C Advantage plan, they need to understand that they still have to be enrolled in Medicare Part A and Part B. They have to understand that they're going to be paying the premium for Part B, whatever that is, whether it's the basic amount of about currently $165, or whether it's a inflated amount based on a income-related Medicare adjustment because their income is higher than what the basic platform is. Even though they're going to pay for their Medicare A and B, they're not going to rely on that essentially at all. Exclusively the coverage that they're going to utilize to cover the costs is going to be through their Part C Advantage plan. Now, the coverage itself is likely always going to be less than the coverage obtained through Medicare Part A and Part B and a Medigap. It's essentially the point of the Advantage plan. It strives to provide less coverage, honestly, to some degree as a cost savings to the insurance company, obviously. But in tandem, the cost for an Advantage plan, the premium cost for the Advantage plan, is usually significantly lower than the cost for a Medigap. If the typical premium for a Medigap is about $150 a month, we're talking about the highest level of Medigap coverage, the best you can find. And it's typical that a Medicare Advantage plan is going to have a premium as low as $0. Not all plans are $0, but most plans are going to be well under $100 a month in premium. And a lot of the plans be a $0 premium. Why? Go back to the premise of how these plans economically exist. They're heavily subsidized by the federal government as a motivation for them to offer an incentive of a very low premium so they can entice individuals into it, so it gets them off the back of Medicare Part A and Part B. It motivates the privatization of the system. And as a result, an individual will say, look, I can get a PPO at a zero premium, and it includes my prescription drug coverage, and it includes dental, and it includes access to a health club, and it includes all these other kinds of things, and it doesn't cost me a nickel. Yeah, I understand I have to pay for my Part B premium, and I don't get to use it, but I'd have to get that anyway if I had option one, and I don't have to shell out for a Medigap, whatever the cost is. I don't have to shell out additionally for a Part D, and I don't have to worry about picking up additional non-medical service coverage like basic dental, vision, et cetera, et cetera. All of this is rolled into the package. There's a certain value to that, especially if the premium is zero. And I'll accept the limitations. I'll accept the fact that I'm going to have cost sharing, certainly more cost sharing than if I had chosen option one. But I see it this way. What I'm going to save in not having to pay for a supplement in a Part D plan, what I'm going to save, which could be like a couple $100 a month by getting a cheap HMO or PPO, at least cheap in premium. But the quality of service is good enough for me. I don't see the doctor that much. I don't use the services that much. Works for me. And plus, I get all these other services that I probably will use, at least initially, more. And yeah, I know there's the risk that down the road, I could get a lot sicker and my needs will be a lot more expensive. And I know at that point, no Medigap is going to touch me because I'd have to go through underwriting, and I'm not going to make it through underwriting. So unless I have some kind of special triggering event, I know that by selecting option two, I'm committed to the concept of option two for the rest of my life in Medicare. Maybe not exactly that product. I can flip from one HMO or PPO to another each enrollment season, but I'm not going to be able to move out of option two to option one. But that's okay, because the money I'm going to save every month, every year, accumulating, to me will more than make up for potential risk of excessive costs. And there's one other thing built in to Advantage plans that mitigates that risk. Every Medicare Advantage plan must have what's called an out-of-pocket maximum amount. And basically what that means is that once you spent out of your own pocket in deductibles and copayments, can't count the premium, but in deductibles and copayments, once you, the beneficiary of that HMO or PPO, has spent whatever that amount is that represents the out-of-pocket max, that's the most you have to spend in cost sharing for the year. So what's the worst that could happen if I have my worst healthcare year? Meeting the out-of-pocket max. Well, how much could that be? Well, depends on how effective you are at shopping for this. And most people don't pay attention to the out-of-pocket max, and they should, because that's the absolute safety net. It says, what's the worst that could happen to you? Well, the worst that could happen to me is I would pay that amount. And once I've paid that amount, then for the balance of that calendar year, the plan year, insurance is on the hook for picking up the balance, whatever that is. So out-of-pocket maxes currently are just a little south of $8,000. But by aggressively looking for less out-of-pocket max products, you can find them for as low as in the 5,000s. And the premiums aren't necessarily that much more. And so individuals will consider, right, for zero premium, which is going to be a couple $100 less than option one, I can have adequate coverage. And if that coverage is not enough for the services I need in a particular crisis situation or an extended care situation, the worst is I make sure I've got a product that has a relatively low out-of-pocket max, and I'm fine. And I'll accept the limitation that the Medicare Advantage plan imposes on me by a managed care network. Yeah, I understand that I can only go to certain doctors and certain providers, but that's okay. My needs are limited, and I'll make sure every year the product I select encompasses the providers I want. And if that changes, I have the ability to change for the next enrollment season, or if I'm caught flat-footed and didn't check as effectively as I could, there's always that extended open enrollment in January, February, or March. It's an alternative mindset that says option one is a guarantee. Option one is a promise that right from the beginning, the entire cost of my inpatient or outpatient healthcare will essentially be covered. It's a promise I can go wherever I want to go. The entire nation is at my access as a healthcare system. And the value of that certainty, the value of that comprehensiveness, the value of not fighting all the time to be guaranteed access to services and not having to battle with a managed care network or a private insurance company, that surety is worth the cost of the premium for the supplement and the premium for the Part D plan. For those individuals that don't value that surety, that instead are looking for what's the least I have to spend in premium, and I'll accept the risk, but the risk is limited with the out-of-pocket max. And as long as I'm okay going to the providers that represent this managed care system, and as long as I understand that I'm likely going to be battling with the private insurance company way more to access more complex and expensive services, battling way more to stay in hospital for an extended period, battling way more to stay in some kind of skilled nursing rehab for a more extended period, battling for an alternative diagnosis, or battling for alternative diagnostic services, or wondering, is this the best I'm getting? I'm prepared to accept that. There's not necessarily a whole lot wrong with selecting a managed care HMO or PPO. And within those contexts, many individuals, and there's another context, it's just so easy. It's just one stop, it gets it all done. I don't have to deal with this. And that in itself could be a value, along with everything else. So how individuals make their decision, how they arrive at what they're ultimately going to utilize, should have everything to do with their understanding what's important to them in the products that are available, what is going to be covered, and as much as possible, and what their expectations of access to services are. And as long as they've done their homework, or as long as they have individuals that help them arrive at an understanding of that, then it's a valid choice. There is no such thing as one option being better than the other as a universal circumstance. There's always going to be the opportunity of either being better for a particular individual based on that particular individual's needs and that particular individual's value of what's important to them. And this should always be the basis of making the choice. As long as what they choose is a choice with eyes wide open, fully aware what the pros and cons are of each product and each strategy, and there's nothing wrong with either choice, as long as it's their choice. Thank you so much for watching this presentation. I hope you enjoyed it, and I hope you learned something. If you would like to know more about our program and the other presentations that we've created on various healthcare-related topics, please visit our website at phbsp.org, or you can call us at 412-266-8322. Either way, I hope to hear from you. And as always, be safe, be healthy. I'll see you later.